Right, I've started the timer and here is your question.
So can I start?
It's 7 seconds.
Okay.
Yes. So if you have read and understood, kindly begin your station.
So after I entered the room, I'll wash my hand. I'll introduce myself and then
Yes.
confirm the name and age of the patient.
Yes.
After that, I'll take the permission from the patient to examine his legs and feet, which will include looking, feeling, and moving of the legs and feet. I'll request the patient to take off the gown and keeping himself on the shorts only. I'll help
Okay.
for the same.
What
I'll
would be
help
the
for the same.
position of the patient?
After
Which you
that,
examine?
I'll ask the patient to stand up.
Yes.
Okay. Before that, I'll ask the patient if he has any pain right now and if he need any painkillers.
Yes.
And also see if the patient is using any walking aid like crutches or cane is present at that time.
Yes.
So that he can stand with the help of that. After that, I'll ask the patient to walk a few steps forward towards the wall and then turn around and try again over his heels.
Yes.
And then I'll ask him to walk over the tips of his toes. While walking, while I'll ask him to walk, I'll
Wait,
be with the patient.
just a second. Can you please name everything that you'll notice on inspection? Do you think you have missed something?
No, ma'am. I started with gate. After that, I'll go
Okay.
for the
Okay.
inspection.
Sorry.
Yeah. First,
Gate
I
is
have
part of
started with,
inspection. That's why I was thinking. Sorry.
I have started with gate, then I'll go to that. Because right now I have told that I will be with the patient so that he
Okay.
cannot fall. I will
Yes.
put one arm in front and one arm behind.
Good.
After that, I'll inspect the patient from the front, sides, and back for any swelling, any scar, or any wasting, any deformities. And
Yes.
then I'll ask the patient to turn around and also inspect the popliteal fossa for presence of any swelling or mass or any scars.
Good.
After that, I'll ask the patient to lie down on the bed and I'll
Good.
say that I am going to feel his legs and if he has any pain right now or anything like that.
Yes.
I'll start feeling the temperature with the dorsum of my hand from starting from below upwards.
Yes.
Then I'll feel the tenderness along the course of the common perineal nerve starting.
How would you compare the temperature?
I will compare
Both
the
legs.
temperature with the opposite side of the
Very
leg.
good. Very good. Yes, you have to mention this.
Whatever I'll do the examination on one side, I'll do on the contralateral
Very
leg
good.
also.
You'll repeat. Yes.
So, and then I'll feel the tenderness along the course of common perineal nerve.
Yes.
Following, then I'll palpate the popliteal fossa if there is any mass or not. After
Very
that,
good.
I'll tap over the common perineal nerve at the neck of the fibula.
What does this sign
to
called?
see the Tinel sign.
Very good.
And I'll see if the patient feels any tingling, pin, prick, or needle-like sensation along the
Yes.
distribution of the nerve.
Yes.
Then I'll start my neurological examination. First, I'll do the sensory examination. I'll take a cotton wick, and
Yes.
then I'll touch the patient over the chest or over the arm and ask that if he can feel it. And I'll say that I'll ask the patient to close his eyes and I'll ask him to say yes every time he feels the same when I'll touch that cotton wick on the legs and
Yes.
foot. So I'll start by touching from the lateral malleolus for S1, dorsum of the foot on L for the L5, then medial malleolus for L4, and then anteriorly over the lower thigh, mid thigh, and upper thigh for L3, L2, and L1. I'll also do for same area for pinprick sensation. And then I'll also do the same examination on opposite side of leg also.
Good. Which side is better to examine first, the affected one or the normal one?
I'll do affected one first in this case, I think.
Shouldn't you be doing the normal leg first to have a value?
I think I have to check it, ma'am, because I'll compare it the contralateral side, that is the normal side. So
Yes.
I think I should do the affected side first.
I think you should do the normal one first, and then patient would be having eyes closed. Then you confirm it with the affected side to make sure damage is there, nerve damage is there. Yes, please continue.
Then I'll start the motor examination.
Yes.
And for hip extension, first I'll ask the patient, I'll put the hand behind his knee, and I'll lift this while asking the patient to stop me and
Yes.
to see the hip extension. Then for hip flexion, I'll ask him to raise his legs against the resistance of my hand.
Yes.
Followed by, I'll ask the patient to bend his knee against the resistance of my hand. Then I'll ask him to straighten the knee against my hand resistance. Followed
Yes.
by, I'll ask him to press my hand with the sole of foot, like he can press the accelerator
Yes.
of the car.
Yes.
And against my hand's resistance. Similarly, I'll ask him to point his foot towards his side, means towards his head side, and I'll against my resistance over the dorsum of the foot. Then I'll also ask the patient to point his grade 2 towards himself, towards his head, and ask him not to let me push it down. I'll do the same on the contralateral side also.
Yes.
And I'll also ask the patient to I'll thank the patient, and I'll just ask him to. I'll discuss the case with the consultant and let him know. I'll help him to
Can you please sum up your case? Yes.
Wash my hand.
Yes.
Yeah. To complete my examination, I'll first complete the neurological examination, what I was doing, including the motor examination, reflexes, and clonus. Yes. Then I'll also examine the patient's spine, hips, and knee examination, and to complete it. Then, so today I have examined.
This is call for you.
1 minute, ma'am. Sorry.
Yes.
Hello. Yeah, walaikum salam. Yeah, fine. How are you? Sorry.
You were presenting your case. So what happened then?
Yeah, so today, after complete examination, I have examined this 56-year-old gentleman who presented with the numbness over the foot, and I think the difficulty in walking also. So on examination, I found there is a high steepness gait, which and also patient had difficulty in walking on heel, and there is also a scar, avulsion scar present over the lateral side of the leg. Yes. And on examination, the temperature is normal, but there is tenderness present along the course of the common peroneal nerve, and also
the tinal sign.
And tinal sign is also positive. Okay. And on neurological examination, there is a decreased sensation over the anterolateral aspect of the leg, and also over the dorsum of the foot. So I did it for light touch.
What are your differential diagnosis?
So on examination, my provisional diagnosis, first I'll consider the foot drop due to common peroneal nerve injury. I'll also consider the sciatic nerve injury, or L4, L5 disc prolapse.
Yes.
Or vitamin B12 deficiency, or peripheral neuropathy due to diabetes mellitus, or maybe some central cause.
Very good. What investigations would you ask for this patient?
I'll advise the patient to start with. I'll advise the electrodiagnostic studies that will include the nerve conduction studies and electromyography, followed by advise MRI of the lumbar spine, lumbosacral spine actually,
Yes.
and also advise the routine blood investigation, including this complete blood count, urea, electrolyte, also blood
What
sugar,
treatment
liver,
can you suggest to this patient?
After discussing the case with the consultant and with the patient, I'll offer
MDT.
the patient.
Yes.
Doing the discussion in the multidisciplinary team.
Yes.
I'll offer the patient first the conservative treatment, which will include the lifestyle modification, use of ankle foot orthosis, physiotherapy for a special muscle training. And then I'll offer the patient surgical treatment, which will include the nerve exploration and decompression or repair. If this nerve exploration, decompression, and repair fails, then I'll advise the patient to go for the tendon transfer.
Tendon transfer, very good. Okay, what parts of examination have you missed? If I would ask you to compare the tone of the muscles.
Actually,
how would you do that?
I was doing the motor examination, then I missed the coordination, I missed the tone, reflexes, and also the clonus.
Yes. So how would you do tone?
Yes, I can do the tone by two methods, by leg rolling test or leg lift test.
Yes.
For leg roll, I will do the roll. I will roll the patient's leg and see what the foot. It should flop. It should flop independently of the leg.
Yes.
If it is not, then there is an increased tone.
Very good.
For leg lift, what I'll do that I'll lift the leg off the bed at the knee suddenly, and the heel should remain in contact with the bed. If it also lifts up from the bed, that means the tone is increased. I'll do this on both sides to compare also.
Yes, good. So, yeah, that's how it's done. Anyone wants to give feedback? Is there anything else you want to add yourself? At the end, you also have, when you're thanking the patient and before you summarize, you have to wash your hand as well.
Yes, yes. I did that, ma'am.
Okay, I'm sorry.
Yeah, actually,
your call came, so I
no, actually.
if you have done it or not. So yeah, right. So I think you have pretty much idea how to do the full top examination. Questions are the same. Yeah.
Yeah, questions are the same.
Once you are doing or once you are explaining, then maybe they can ask you how to check the clonus or how to do the coordination. Then you can tell. But now I've tried to ask you the way you were presenting.
Yeah.
It was good. Thank you.
Thank you, ma'am.
And here is your question. Right, so if you have read and understood, kindly identify. What are you looking at? Can you identify, please?
Okay, this is the internal surface of the skull from the inside.
Okay, can you please tell me what are the parts? What is this part?
Yeah, this is anterior cranial fossa and the middle cranial fossa and the posterior.
How do you divide anterior, middle, and anterior, middle, and posterior cranial fossae?
anterior cranial fossa different from the middle cranial fossa by the lesser wing of the sphenoid on the lateral side, and the anterior cranial fossa contain frontal crest and crista galli and the cerebriform plate of the ethmoid, and the anterior and the posterior ethmoidal nerve, and the anterior and posterior ethmoidal foramen, and the orbital plate and the orbital part of the frontal bone, and
Can
the
you
frontal sinus.
Yes, can you please tell me what are the contents of posterior cranial fossa?
Yeah, the content of the posterior cranial fossa, the cerebellum, and the houses of the brainstem.
Okay. What are the contents of middle cranial fossa?
The content temporal bone.
Temporal lobe. Brain.
Yeah, yes, temporal lobe of the brain.
Okay. If we come here on the posterior cranial fossa, what is this 11 opening for?
This is foramen magnum, extend from the anterior condyle and to the posterior condyle.
What else? What is transmitted through this foramen magnum?
Yeah, the foramen magnum transmit anteriorly الأبيكال ligament and the membrana pectoria, and posteriorly lower part of the medulla oblongata and the tonsil cerebellum and the spinal part of the accessory nerve, and the three dura and the dura and the bea and the arachnoid, and the three artery, two vertebral artery and one anterior spinal artery, and the two posterior spinal artery.
Spinal root of, okay, and any nerves?
Spinal root of the accessory nerve.
Okay, and tectorial membranes?
Tectorial membrane and apical ligament, and three
Apical ligament of the dens. Okay, very good. All right, good. And then if you can tell me what this 30, if you can identify this 30 and tell me what this is.
What's mom?
This number 30, can you see?
This is jugular foramen.
What is transmitted through this foramen, please?
The jugular foramen transmit anterior part, inferior petrosal sinus, and the middle part transmit glossopharyngeal and figus, and the accessory nerve, and the posterior part transmit sigmoid sinus with the continuation with the inferior petrosal sinus to the form internal jugular vein.
Okay, very good. Can you tell me, can you identify this ridge 27?
This is hypoglossal canal.
What is transmitted through this canal?
Yeah, transmit الhypoglossal nerve.
Okay, good. If we can come here, and what is this 6?
6. This is crista galli.
What is it? Can you explain?
What's mom?
What is crista galli?
Yeah, the crista galli. This is the free crista galli. This is the attached border of the fulcus cerebri. This is sickle shape of the dural fold attached to the frontal to the frontal crista between the frontal between the frontal crest and the crista galli. This is the foramen. This is the foramen cecum.
Good. Can you please tell me what are the attachments on styloid?
Styloid, 3 muscles: stylohyoid muscle, styloglossus muscle, and stylopharyngeus muscle, and 2 ligament: stylohyoid ligament and stylomandibular ligament.
If there are metastatic lesions, lytic lesions on the skull, what might be the causes?
Yeah, could be skeletal metastasis like follicular carcinoma metastasis to the skull bone. Could be a Paget disease. Could be sarcoidosis. Could be osteomyelitis. Could be sarcoidosis.
What is terion?
And multiple myeloma.
Yes, very good. What is terion?
Yeah, this is H-shape formation between the frontal and parietal and the greater wing of the sphenoid and the squamous part of the temporal bone.
It is located, or it's part of which cranial fossa?
What's mom?
Terion is part of which cranial fossa? Anterior, middle, or posterior?
The middle cranial fossa, because the located of the located landmark for the middle meningeal artery.
Artery. Okay, just beneath. Okay. Injury of middle meningeal artery can lead to what?
Can lead to extradural hematoma and can lead to contralateral paralysis.
Okay. Right. Can you tell me what passes through the optic canal?
Yeah, the optic canal passing the optic nerve and the ophthalmic artery.
Yes, optic nerve and yeah. Okay, good. Okay. Can you please tell me right, or I can ask you. Foramen rotundum, what passes through foramen rotundum?
الفورامين روتندم passes الماxillary division of the trigeminal nerve.
Can you identify foramen rotundum here on the skull? Which number is foramen
Yeah,
rotundum?
foramen rotundum number 13.
Isn't it here? Is it 13?
Yes, 13.
Okay. But it's this one. Okay, 13. There. No. It's
13,
this
yeah,
one.
yes, this, yeah,
Okay.
below the lesser wing of the sphenoid.
All right, okay. Can you tell me how many venous sinuses there are in the posterior cranial fossa?
The sinus in the posterior cranial fossa, this is inferior sagittal sinus with the join with the great cerebral vein form a straight sinus, and the straight sinus drain to the confluence sinus, and the confluence sinus drain to the transverse sinus and the sigmoid sinus, and the superior and the inferior petrosal sinus with the sigmoid sinus to form internal jugular vein and the left transverse sinus.
Very good. Where are these intercavernous sinuses formed?
What's mom?
Where these intercavernous sinuses are formed?
Yeah, the intercavernous sinus and the cella thrisica classified anterior and the middle and the posterior intercavernous sinus drain into the cavernous sinus as a single part of the cavernous sinus.
Very
At
good.
38.
Excellent. Yes. All right. Very good. Excellent.
Thank you, Ma.
Yes. Question.
Yeah.
Right. So if you
Okay.
have read and understood, kindly tell me, considering it critical care scenario, how would you manage this patient?
Yes, ma'am. I'll manage this patient according to the 3-stage assessment. First, I'll do the patient's physiological status, and then I'll discuss the case with the ward nursing staff, and then I'll do the immediate management of the patient according to the care of critically ill surgical patient protocol in the ABCDE format. First airway, and then breathing and circulation, and finally disability and exposure. And after that, I'll do the full patient assessment. I'll review the drug chart, as the patient didn't get the proper analgesia before. So I'll start see if as I have seen that analgesia is not given properly. So I'll start immediately one analgesia. And then I'll take the proper history and full examination by doing the
Yes.
secondary assessment.
Considering it critical care scenario, how should a pain management be done?
In this case, patients
Yes.
should be given according to the WHO ladder.
Very good. How do you
Patients
do
should
that?
have we should start the step 1 of the ladder, step 1 with paracetamol alone, and or some weak NSAID. And if patient did not get the relief from the pain, then we can go to step 2, where we add the paracetamol with NSAID, and also can add some weak opioid analgesics. But if a patient still cannot get relief from the pain, then in a step 3, we can put the patient on a strong opioid analgesics along with some NSAID.
How do you know when you're giving steroid or when you're adding steroid? How do you know that you've reached the maximum limit? How would you evaluate? What are the signs and symptoms you look for?
Okay, sign and symptoms of pain. Okay.
No, not pain. Opioid overdose. You have to listen.
Yes.
You have to understand the question. Yes, you said
yes,
the
yes.
last resort is adding of opioid. So
Yeah,
then,
yeah.
how would you know? Yes.
Opioid can have the acute side effect and can have the chronic side effects. So in case of
Yes.
acute side effects, there can be respiratory depression,
Very good.
can be nausea, vomiting, constipation. Patient can have sedation also. Also, there will be urinary retention,
Yes.
or patient also can have like seizure or what we call delirium. In case
Delirium,
of acute
yes.
effect, yes.
Confusion, yes. Or in case of extreme cases, patient can even have pinpoint.
Respiratory pinpoint people also.
Yes.
Yes.
All right.
Meiosis,
Okay.
yes.
Considering pain, how would you define the term pain? How would you know that it is pain? When would you label it a pain?
So pain can be defined as, yes, what we call, sorry, just 1 minute.
Unpleasant.
Yeah. That's what it is. Actually unpleasant. That is what I am missing. That is emotional. Yeah,
Emotional
unpleasant
and sensory,
or
yes.
emotional and sensory experience, which is caused due to the actual or potential tissue damage.
Very good. Can you tell me about the pain pathway? From
Yeah,
where it
pain
starts
path.
and how it goes? Yes, please.
Yeah, pain pathway starts in the anterolateral. Actually, it from the peripheral. Actually, from the peripheral nociceptor.
Very good.
Yes, from the peripheral nociceptor, it enters the spinal cord through the dorsal horn of the spinal cord. Okay, and then through the lateral spinothalamic tract, it reaches the thalamus, and from there it reaches the what we call somatosensory cortex.
Yes, very good. Okay, there are certain pain scoring systems. Can you name few?
Yeah, we know certain pain scoring system like verbal visual analog scale, where we do it from no pain to worst pain. Then there is a numeric scale, where we rate the pain from 0, which was no pain, to the maximum 10, which is the worst imaginable pain patient can imagine. There are certain other also the what we call verbal scale. In verbal scale, we ask the patient if it is absent or mild or moderate or severe, or I think there is there is discomforting or excruciating pain. Yes.
And they are also graded as 0 to 4.
Yeah, absent is 0
yes.
and excruciating.
Can you please tell me something about the functional assessment of pain scoring system? How is it done?
Functional assessment. In functional assessment, we see whether the affected part of the patient's affected body part, if he can move or not, like if there is a leg affected, so due to the pain, if the patient can move or not, if it is affected part is chest or abdomen, so if patient can cough or not, if respiration is affected or not. These are the functional assessment of the pain.
Okay, this patient, nurse comes to you and tells you that patient is still in the pain. After looking at the patient's chart, what more would you add in her pain management?
I'll add morphine. With
how much and yes, how frequently? What is the normal dose of morphine that you are going to add?
A normal dose of morphine is usually, I think, 1 to 2 milligram.
0.5 to 2 milligram, bolus.
Okay, 0.5 to 2 milligram, yes.
Okay. Then how frequent would you give?
Actually, if I will do the patient controlled analgesia.
Okay,
then
yes. What is patient controlled analgesia?
Patient control analgesia, it consists of a machine where there will be means battery controlled syringe pump, where it is connected to the IV line of the patient, and patient
not battery
can
controlled, it's electronically controlled infusion.
Okay, and electronically controlled infusion pump, where it is connected to intravenous IV line of the patient, and where patient can self-administer the bolus.
Okay.
He can press it and self-administer it. Then
can you name few complications which can result because of the use
first
of
thing? First thing is patient has to be alert to self-administer it. Second thing, patients should be oriented to do it, and also because it is electronically controlled, so it can be, there can be technical error, there can be battery run out. Also, patient has, whenever he has pain, he has or she has to wake up and do it itself, which causes sleep disturbances. And if patient is handicapped, he cannot do it itself.
Yes,
also, patient has to stay on the bed, so it will decrease the mobility of the patient.
Okay. Bell has gone, so I'll allow you to go with one last question. If you fail to manage the pain, what are the complications of the pain that can occur?
Okay. If there will be pain, complication will be first, like we'll start with in cardiovascular system. There will be tachycardia, can have hypertension, and due to this, there will be increased oxygen consumption of the heart, and so due to increased demand, there can be risk of myocardial infarction. And if the abdomen is involved, there can be reduced gut motility. There will be paralytic alias. And in case of a respiratory system, there will be decreased movement of the chest, leading to the retained secretion. There can be pneumonia and atelectasis. In case of musculoskeletal system, if lower limb is involved, like patient cannot move the lower limb, it can have the risk of deep vein thrombosis. Like that, similarly, there will be psychological effect also, and
others. And others, when there's like this one is post-op patient, so there'll be poor wound healing, etc.
Yes, there will be poor healing.
Very good, very good. Okay. All right. Thank you so much.
Thank you, ma'am.
In the beginning, did you say you'll manage it with ABC control or CRISP protocol?
I said I'll manage with CRISP protocol in ABCD format.
Yes. Okay. Yes. This I missed. So because this is not that normal, this is post-op patient and first post-op. So it's an emergency. You'll take it seriously and you'll do it with the CRISP protocol.
Yeah. Always, all patients should be with the CRISP protocol.
True. Yeah. So anyone else want to give feedback? that was, I think, it. I was only confused about this first thing. Other, I think you did well. And maybe once you'll read it once more or listen to the recording, then you'll realize you have to answer spontaneously, because if you'll think you'll answer, you're wasting some amount of time. But anyway, otherwise it was good. You had the whole knowledge, and
Yeah, actually, I think I have missed. Actually, due to time, so many questions have left. I think
because
maybe.
of the time, bell went, and I couldn't
Yes.
ask you all the questions. But I did ask you enough to evaluate you, that you have enough knowledge on the topic. So I think it's nothing to worry about. You are still in the safe zone. And before exam, if you'll just read it once, it will be enough,
Yeah.
hopefully. Good. Thank you.